Thank you. And Yorgos is a graduate student, also moderator, who has been involved in the development of the back end of what you're about to see now. So I'm a clinician, I'm also a researcher. I have been working in the AEGLE project, and it was actually my first experience with big data. It was very interesting working with this group of people, and we have learned a lot during these past 3 years. So first, from a clinician's perspective, why would we need a decision support system in intensive care? What for and how that would be implemented? This is the first part I will try to show you from the clinician's perspective, not from the technical perspective. Why do we need a CDS in the intensive care unit? Well, because there is usually 1 or 2 of us and many patients. Each and every one of those patients have many problems, so we cannot really address them all at the same time and at the level of excellence we would like to, and especially our patients would like to. Our monitoring and life-supporting devices produce a really large amount of data that we more or less process with our brain processor, but there's still room for improvement and a need for help. What we would like to deliver is precision medicine and personalized care, and in this aim, we could take some help. What for? Which aspects of intensive care are best suitable for support by a decision support system? Well, obviously, we have to have adequate electronic data. We cannot support decisions that are based, for example, on the physical examination of the patient. This is not adequately documented in the electronic format. We have to target aspects of our care that are not adequately addressed by the basic monitoring that we already have. So I don't want the decision support to tell me about asystole because every alarm on the patient is beeping at that time. Also, we should target aspects of the care where complicated calculations are needed. Things that we just do not have time, or the motivation to do it at the bedside, and stuff of care that rely on the continuous analysis of waveforms. This we can do quite well if we stand looking at the monitor screen 24/7 per patient. That would be a way to increase jobs for doctors in the ICU, but that wouldn't be the most cost-efficient way, probably. So, with that in mind, the aspects of intensive care that in AEGLE we have addressed are mechanical ventilation, nutrition, and general deteriorating trends. And a little bit on the how. Safe access to patient data is a major concern. We have been talking about it for about a day and a half now, and it has been a major aspect of our work in AEGLE, and just as you heard, his presentation has contributed a lot to that. A CDS should have validated algorithms if we have to make clinicians trust us. So we do need to provide things that have been validated. The suggestions have to be actionable. They don't necessarily have to be, do that right now. And information that better characterizes the patient is also a very welcome information. If the patient is going better or if he's at higher risk of death, is something I would like to know, because after the first day of ICU, patients stay in this in limbo condition where we don't know which way things are going. CDS in medicine come in 2 flavors. The closed loop, where the computer decides and then acts upon the algorithm without the interference of the doctor. We don't like this flavor. We don't like, us lawyers will have to be there present to implement the rules. We doctors want to be there to implement the suggested actions. So we opt for the open loop system where the decision support gives us a suggestion, but we do go there and actually physically do or not do something. So a little bit of a description of what the CDS is reasoning is behind. Patient data are uploaded, anonymized. In the cloud, the analysis of the algorithms that have been developed are performed, and this is eventually returned and provided to the medical or nursing staff, the healthcare practitioners, for their information and actions. I will try not to go into much clinical detail since most of you are not from a clinical background, but I will still give you some. Why, and we have focused on what we have worked on and why we think it is important. So mechanical ventilation. We think highly of mechanical ventilation in intensive care because this is actually how intensive care units were created. In the 50s, during the polio epidemics, the need for mechanical ventilation created the ICUs. So it's our pet thing in the ICU. Ventilation is a supportive measure, but inappropriate ventilation can actually kill. We wouldn't like our ventilation to kill the patients. Ventilator alarms, the currently available ones, are highly insufficient. They provide very, very little information at the very last minute of when things are going wrong. Especially on assisted ventilation, so this is when the patient is not completely sedated, but he has started breathing and the ventilator is trying to help him. With that, there is the same highly variable breathing pattern that we have now. As I am talking, my breathing rate is completely varies from second to second. This is also happening during ventilation in the ICU, and because this is highly variable, if I'm just looking at this patient now and he's doing fine, the minute I walk to the next bed, he may be doing something else and something I do not like. This is something that has to be addressed with data science because we cannot really do it any other way. And this is what we have tried and worked on. Now, one of the most common problems during assisted ventilation is a patient trying to breathe but not getting the ventilator to understand that and not getting the ventilator to support his breath. That feels a little bit like suffocating, so it's very stressful to the patient, and several studies before ours had shown that it can increase patient morbidity and mortality. Using algorithms that were developed within this project, we identified and described the clusters of ineffective efforts. We named them events, and we showed that the ineffective effort events, so when this thing is happening repeatedly and over a short period of time, is more important to patient outcome than just sporadic ineffective efforts. This has been a breakthrough in the literature. People were doing it in a different way before us, and we are very proud to say that now it is considered the state-of-the-art way to analyze this particular aspect of mechanical ventilation. This publication is not from our group, and we were not in any way involved. It's just showing that the state-of-the-art way to analyze is through identifying the clusters the way we proposed. So the CDS solution in AEGLE helps doing exactly that, identify and visualize the ineffective effort events. It provides alerts for the presence of ineffective effort events, and it also allows the visualization of all patient ventilator interaction monitoring parameters and giving indications for causality, so the physician can actually know what to do when he goes at the bedside to correct what is happening. Also, a more complicated algorithm alerts the physician for a patient with an increased risk of death based on those PVI parameters, and also integrating the electronic medical record parameters. So this is what the CDS looks like. A little bit more introductory. Here we can select the number of beds to put for monitoring, and we can see them all there. Anything that's red means that at some aspect available for the CDS, something is going wrong with this patient. And now we select the patient in bed number 2, and we can see that he has an alert for an ineffective effort event, which you can see here in green. On the exploratory part, now he's having this event, what am I going to do? These are parameters from the monitoring device, each one describing one parameter of the respiratory system, and we can clearly see that this green one, the change precedes the appearance of the event, indicating causality. So when I'm going to the bedside, I'm not going to look for anything and everything, I'm going to look for that parameter of ventilation and of respiratory system dysfunction. Parameters describing the event, like the power and duration, are also available here. And if I don't remember a lot of things about this patient, if I just came back from being 5 days in another city giving lectures, I can get some hospitalization info about this patient, like how many days has he been on the ventilator, how sick he is, how bad is his oxygenation. Like here, this patient is really bad. This below 100 is as bad as it gets. So information like that are easily provided for our review. So cool. We have focused on mechanical ventilation a lot because we believe there is a significant gap in the available solutions there. I'd like to point out here that the MIMIC database, referred previously as the largest available, does not have information on mechanical ventilation. So another aspect that is very important for the clinical outcome of patients during assisted ventilation is the pressure distending the lungs. So you may be able to imagine intuitively that if you inflate a balloon at very high pressure, it may actually break, and this is something that more or less is happening to the lungs of the patients. So we have known from the literature for about 20 years now that high pressures are associated with injury. Recently, we show that monitoring this pressure is feasible with a specific type of commercially available ventilator. And through AEGLE, we have developed algorithms that allow the calculation and visualization of these pressures. Although the data are derived from a commercially available ventilator, the company of the ventilator does not provide this analysis, so this is a unique feature of the AEGLE platform. And we have developed alerts informing the physician both when the pressures are high, but also predictive analytics to say when the pressures will be high in the next few minutes, so we can have more actionable alerts. Yes, so I can try to show you here. Let's look at another. So we have also asked our technical team to allow us to show at the same time signals coming from two completely different sources. The one being the ventilator and the other one being the monitor. So because I sometimes may think that something happening to the breathing pattern may affect for example, the stress response that can be indicated by the heart rate. So you can see here in green the pressure that is calculated, and here in highlighted an alert that at this time the patient is at risk and will probably develop in the next minutes high pressures. Again, I will not show you the hospitalization info, and as you can see here, a man of age 73 and weight of 72. Basic information are shown on the right. Well, moving away from mechanical ventilation and exploiting the available electronic medical record data, we have focused on nutrition. Well, nutrition is a very important aspect of ICU care, and the one that does not receive adequate attention. Why? Because patients never come to the ICU with a nutritional problem. They come because they broke their head, they have bleeding, they have sepsis. Nutrition is not the main focus. Computing the needs of the patient is a complicated task that requires input from several parameters, and it takes some time that we do not really find the time to do it. More importantly, the current available guidelines do not provide information how much exactly we should feed the patient. So physicians can choose to select different targets based on what they believe is more appropriate. And we hate to admit, but we sometimes just neglect to feed the patients. But if it's any better, we forgot to feed themselves sometimes, not rarely. So the CTS user interface provides some solutions for these requirements. It calculates the needs and estimates the deficits, allows us to visualize the delivery so we can see what we're doing and maybe remember that we should do better. It alerts in case we don't just respond with a visual. We can have an auditory also signal that we are going below the set targets. We allow the physician to set the targets because there is not one generally accepted. And we have developed predictive analytics based on nutrition and the electronic health record data that alerts when a patient is not doing overall well. So here we can see during this patient hospitalization, the percentage of the required calories according to the calculated needs. What did we deliver? Initially is nothing. We went up to 60% and then kind of not did so well. And because reviewing nutrition is something that can be assigned to the nurses task too, we have formatted the screen to review all patients available in the CDI simultaneously. And you can see here that at this specific time point, these 5 of the 6 patients are not receiving adequate nutrition at all at this moment. This one is being fed. And in blue, it means that it is adequate based on the threshold I said here, so 20% of the required calories. And based on this threshold, these 2 patients have been fed adequately through their hospitalization, but these others not. But giving them 20% may be my point of view, and if someone else felt that they wanted to see who receives 50% of their needs, things would look a little bit more red. So we can have an interactive and allow the physicians a lot of flexibility when reviewing these records. And finally, a more overall analysis of the electronic medical record. Sometimes minor but significant changes may go undetected, especially if it happened on a patient who is in a relatively more stable condition, even more if the patient, the next bed is having a very bad moment or have a new admission. There's reliance on human factor, and reviewing what actually happened when something has gone wrong is not always easy. So what we need is to be able to visualize concomitantly signals from different sources, and we need to be able to review severity scores and parameters of disease easily and we have developed an alert for deterioration based on predictive analytics. So, norepinephrine is the main drug that we use to regulate blood pressure in a patient. And the information comes from the pump that infuses the medication or the input of the nurse on this source, while the mean blood pressure is coming from the monitor. But because these are connected, not physically, not in the electronic medical record because they come from different sources, but in our minds and in the patient, the one is directly related to the other. When I want to review what's happening to the patient, I want to know not only what his blood pressure was, but also what amount of vasoactive medication he was receiving at that time. So this is what this graph shows, and we can see that, well, at that point the patient obviously died. So this is for the clinical decision support system developed. You can ask for a demo. We will soon have data from patients, real ICU patients, that you can use for playing around with this demo and see how it works. So I will stop now and take any questions before continuing with the next presentation on the R&D. Thank you.
Shorten days in the ICU or maybe reduce costs?
You will, at the presentation right after the next one that I finish, present some data on health technology assessment of this tool. It's difficult to change the outcome based on a monitoring device. First of all, monitoring device by definition do not change outcomes. Our interventions do. So there no single monitoring device has ever shown to change the outcome in the ICU. We can rely on the differences in outcomes based on an effect happening or not happening. For example, when it comes to ineffective efforts, we have seen that there is a big difference in the patients who have events in terms of ICU length of stay and outcome with the patients that do not have. Without the monitoring device, it is not feasible to correct this. And so without the monitoring device, it's not feasible to run the trial to see to which extent we can correct this, so to which extent we can actually make the people who have events behave like the ones who do not have. So it's not so straightforward to get answers. You have to have the technology to implement it, to run the trial. As for nutrition, it gets even more complicated because even with optimal nutrition, basically it's the disease that defines outcome. But we do think that in all aspects that we have addressed, each and every patient, if he was breathing more regularly, if he was receiving his optimal nutrition, he would do better than without.
Occasionally you were mentioning predictive analytics. Could you say what you mean by that and how well they perform?
Okay. The ineffective effort event is a definition that we have developed, so the analytics that identify the ineffective event of a horse have 100% accuracy because we have identified that. For the prediction of mortality associated with ineffective efforts and electronic medical records, the accuracy is, of course, much less because other factors influence patient outcome more than ineffective efforts. So they are meant to be more of a suggestion, but we can provide with a detailed percentages of each and every analytic we have and their accuracy based on the current on our data, because this has been, the algorithms have been developed with the data from this ICU. Apart from the PVI, from the ineffective effort events, in which case our data have been validated with an external data set. And in this data set, we have seen that indeed the presence of ineffective effort events is more important determining the outcome of patient than ineffective efforts alone. So in this case, we can say that they do contribute. Again, it's not the main determinant of patient outcome. You can imagine that if someone has hurt his head, has a severe traumatic brain injury, whether he breathes nice and smoothly or not cannot really determine outcome. The brain injury is what determines outcome. But for all predictive analytics, we have the detailed report of percentages that we can provide if you want.